you have healthier sperm if you ejaculate more frequently.
Would you then argue that ejaculating more frequently in general is good for the health of the individual?
That's a tough one. Getting a fertility check is a double-edged sword. If you're tired, you're fatigued, you're stressed, all these things are going to influence, partially the amount of ejaculate as well as the velocity and what you're going to experience. So people with lower testosterone do die at younger ages than men with normal testosterone levels.
Welcome back to the Rena Malik MD podcast. I'm your host, Dr. Rena Malik. Today, our guest is Dr. Jake Fantus. Dr. Fantus is assistant professor at Kansas University Medical Center in the Department of Urology, focusing on men's health. He is a prolific author and has published over 50 peer-reviewed articles. Not only is he an excellent urologist, but he is a wonderful friend. He was actually my junior resident in training and truly turned out to be an outstanding urologist and, more importantly, a wonderful human being. Today, we talked all about infertility. How can you prevent infertility? And what about when you're trying to conceive? Are there certain positions or is there an optimal timing for sex to actually have a baby? We also talked about a lot of things that you can do to prevent infertility. And what about those cold plunges? And do boxers or briefs really make a difference? And we talked about how sperm is maybe a biomarker of your overall health. We talked about should you be getting a semen analysis just at a baseline? And also, what about vasectomies? Can you really get them reversed? And what is that process like? Lastly, we talked about testosterone and why it's declining in young men. And what does that mean? And why might it be happening? I hope you guys enjoy this conversation as much as I did. The first 50 minutes or so, you won't be able to see Dr. Fantus, but you will be able to hear his voice. This is due to us having a video recording issue as this is recorded off-site. And we decided to keep the content because it is just so wonderful. If you want to see Dr. Fantus, fast forward ahead to 50 minutes and listen to the rest of the podcast in audio form. I hope you guys enjoy. Welcome, Dr. Fantus. Thank you so much for joining us.
Thank you so much for having me.
For our audience, I just want to let you guys know that Dr. Fantus, Jake, was my junior resident. And so you may see a little rapport with us that's not typical of me and my guests, but he was an excellent junior resident and he is now an excellent expert in infertility and sexual medicine. And I'm so happy to have you here.
Well, yeah, thank you again. And I'd just like to add, you're an excellent chief resident.
Thank you. Thank you. We can maybe at the end, you can tell them what you really thought about me. So we're going to talk about infertility. So let's talk about the landscape of infertility. How common is it?
Unfortunately, infertility is fairly common. Up to 15% of the population struggles with issues with conceiving children. I think it's really important to kind of define what infertility is. Infertility is the inability to conceive a child after unprotected, appropriately timed intercourse over the course of a year. And afterwards, 85 to 90% of people are likely to conceive. And if you haven't, you may want to be evaluated for infertility. The question I get a lot is, are men more likely to be infertile than women? I mean, there's been somewhat of a paradigm shift that we try to do the evaluation of men and women simultaneously now, where originally we would just evaluate the woman, and if there wasn't a problem, only then would we evaluate the man. And we're realizing that up to 50% of cases of infertility are either a male issue or a male and combined female issue.
So you said appropriately timed intercourse. What does that mean?
This is challenging. So there are tons of great apps. There are things you can go to Walgreens and CVS to buy sticks to urinate on to figure out when somebody's actually ovulating. And if you look at some of the data, there's a very tightly regulated window. And we're talking this 3 to 5 day period in some cases where if you're not having intercourse during there, your chances of having a child drop pretty darn close to zero. So being able to track those cycles and then being able to have intercourse at least once, if not once a day or once every other day in that cycle, again, your chances of conception are pretty low.
Is it better once every day or once every other day?
Well, it depends who you ask. I mean, traditional literature really showed that every other day may have better semen parameters and higher chances. I think I would challenge that slightly. There's some more contemporary literature that shows that it probably doesn't matter between every day or every other day. And then if you start moving the envelope even forward, we're realizing that multiple ejaculations, again, depending on your semen parameters, multiple ejaculations may reduce some of the reactive oxygen species, damage sperm, meaning that you have healthier sperm if you ejaculate more frequently. How that translates into necessary pregnancy rate, I think, has yet to be determined. But we do know that the more time sperm spend in the male reproductive tract, in the epididymis, which is the structure behind the testicle, going through the vas deferens, going through the urethra, that they accumulate this DNA damage. Because unlike the egg, the sperm is a differentiated cell. It has no DNA repair mechanisms. So once that DNA damage is induced, it's completely relies on the egg to actually undo any of that damage. If it's too far damaged, obviously be failure of fertilization.
We're going to talk about how semen parameters may translate into health, but presuming that semen parameters are a biomarker of overall health to some degree, and we can talk about that, would you then argue that ejaculating more frequently in general is good for the health of the individual?
That's a tough one. I do think that a lot of those studies looking at more frequent ejaculations, anytime I see a paper that, has two comparisons, you're always wondering, what is the left out third comparison here? And we know that people ejaculate more frequently are probably more sexually active. We know people that are more sexually active are probably more active in general, have lower cardiovascular risk factors. Do I think specifically ejaculating is going to make you healthier? I think the jury's out. I probably wouldn't say that, but I do think that a lot of the things it's associated with, again, sex, physical activity, are certainly ways to be more healthy. In terms of optimizing your sperm parameters, again, I think every other day or every day in that fertile window will put you at normal risk for, having a pregnancy.
So let's say, I'm just thinking outside the box here. Let's say you're with a partner who's like, I can't have sex every day, but I can have sex during that 3 to 5 day window twice. So should the male then try to ejaculate on the other days?
Probably not. And the reason, again, this is a probability function, right? You are trying to optimize the number of living functional sperm in, right next to the cervix during this time. So if you're ejaculating your partner every day, let's say theoretically, day one, you have 150 total modal million sperm. Day two, you ejaculate, you have 100 million. If you hadn't ejaculated, you would have had 200 million. And again, these are completely hypothetical, made up numbers. The person who's ejaculated twice in their partner has 250 million chances of having a child, whereas a person who ejaculated once has a 200 million chances of having a child. So again, I really think it all comes down to a numbers game. I mean, male factor is challenging because on the female side, there's a 1 or a 0. You're ovulating with a healthy egg or you're not. And the male side, I get these semen results back and people are dismayed. They look like, well, these numbers are abnormal. Like, you still have 100 million healthy sperm that could conceive a pregnancy. So it's difficult sometimes to interpret these bulk semen parameters because the signal we're looking for is pregnancy test or fertilization. We're looking for, a fetal heartbeat, and we're looking for a live baby at the end of the day. Nobody really cares what their semen parameters are if they're not having a child. And likewise, if they are having a child, they probably don't care if theirs are slightly lower than normal.
So we'll talk about if you should care about your semen parameters, which I think you've alluded to that you shouldn't, but let's talk just a little bit about physiology. How long does it take to replenish the number of sperm after you ejaculate?
The life cycle of a sperm is between 72 and 74 days. If you're having repeat ejaculations, I think these are two separate things. The one question is, how many live sperm I ejaculate? If I ejaculate 3 times, I've noticed the volume of semen is decreased. The number of sperm, it would take quite a few ejaculations to have your numbers drop significantly. In terms of the amount of fluid, however, you got to remember that the ejaculate is comprised of several different things. The amount of sperm is less than 5% of the ejaculate by volume. I mean, we probably talk about vasectomies, I presume, but that is a really common question, is what's going to happen to my ejaculate? And really, sperm make up a minority of the volume. The rest of the volume comes from the seminal vesicles and the prostate. But as we have repeat ejaculations, again, that's going to drop off somewhat precipitously. So regardless of how many sperm are in it, you may not have the vehicle to get them, out of your penis.
Got it. We've kind of alluded to sperm, the number of sperm you have and the health of that sperm. Is that a biomarker of health?
I think it is. I really do think it is. Dr. Eisenberg's done a lot of work in this area, looking at both subfertility, so just people that are having lower rates of fertility, as well as, total number of sperm or people with no sperm, condition called azoospermia, and patients' overall health. I think there probably is some degree of a bidirectional relationship here, meaning that people with morbidity that have, uncontrolled diabetes, high blood pressure, aren't taking care of themselves, may have some endocrine-related consequences that drop their sperm counts. But on the flip side of that, some people with these potential undiagnosed genetic conditions who have lower testosterone levels due to these also may manifest some of these things like high blood pressure, obesity, because they had a decreased testosterone, which then decreased their sperm count, or some overlap in these genetic conditions. I think it's an excellent biomarker in a lot of ways. From an evolutionary standpoint, you would imagine that reproduction is important, but living is probably a little bit more important than the ability to procreate. So your body prioritizes kind of what parts to shut down when you need to optimize other parts of your health.
If you need to live and you have other comorbid conditions, it's going to prioritize shutting resources to those things rather than optimizing sperm health.
Exactly. And then again, for those men that may have some either environmental exposure that cause a problem with their sperm, it's likely that it has other effects, on their body, or they have a genetic condition, something that I see frequently as Klinefelters, where men have very low sperm counts, decreased testosterone levels, again, typically associated with being slightly overweight and a number of other conditions. But those are the things we talk about as this being potentially a gateway into men's health, is that sometimes their overall clinical picture is related to their sperm count. I would be careful to over apply this concept. So if you get a semen test and your sperm aren't perfect, that does not mean that, you are going to get any of these conditions. But it is definitely something that I use as a platform to say, if you haven't seen your primary in a while, if you are only seeing me because you took a at-home semen test and it was low, I certainly would reestablish with them, because I do not check cholesterol. I don't typically check the A1Cs in patients, but these are the things that I think as urologists and as physicians we miss sometimes, is actually finding an entry point to push these people back into the health system.
Absolutely. I mean, I think I actually do test all those things in my patients when they come in with sexual dysfunction, because sometimes I'm the only person they've seen. And it is then I can say, look, your cholesterol is high. You need to see your doctor and work on your diet and exercise. You mentioned environmental exposures. So what environmental exposures should people be avoiding to optimize fertility?
Something I talk about a lot is wet heat. Like hot tubs, wet saunas. There's this article in the International Journal of Brazilian Urology that a lot of my colleagues quote about decreased sperm counts in men that have no way of heat escaping the scrotum and the testicles. I don't think it's a perfectly done study. I mean, when I tell most patients about exposures, the question is it helping you? And if it's not helping you and it could be harmful, you should probably stop doing it. That's a big one. Illicit substances, I think that, we can talk a little bit more about specific illicit substances. The jury's out on some of them, but I think in general, probably not going to help your fertility. Not getting sick or exposing yourself unnecessarily to people who are sick. That's a big one. I have a lot of men that come in with a semen test that's abnormal, and they just had a viral illness and a fever. Really, again, it doesn't matter what virus, doesn't matter if you have COVID or bacterial infection. People with fever, we know, reduces sperm count sometimes to zero, or the motility to zero, which can be very scary news if it's not put in context. And then I think avoiding any kind of, harmful chemicals, radiation, heavy metals, things that you probably already avoiding in your life, that if you came in contact with, you would probably see somebody. I mean, those are really the big ones.
Yeah. And I think I'm cautious also, though. I mean, we all are exposed to some degree to metals in the environment. We're exposed to some degree to environmental disrupting chemicals and microplastics. And I think stressing about those things is challenging. And there's certain things you can do to avoid them, but you can't avoid them all. So stress is also a huge inhibitor of a semen quality, right? You have higher stress levels that translates to more reactive oxygen species and more damage to sperm.
Yeah, and independent of that, stress affects your testosterone, which then also affects your sperm. So I think it's a vicious cycle. It's hard. You can't tell somebody to not be stressed out. I think it's very challenging. Like, I know you're stressed about your fertility concerns, but stop being stressed. Help your fertility.
I know. It's like I tell patients, like, do what helps you with stress. And that might be meditation, that might be going to the gym, that might be going for a walk in nature, like whatever it is. I can't tell you what that is, but like you have to sort of investigate that and implement that. And that takes work and effort.
Yeah, but I mean, it's really important. I mean, you said it already, like a lot of these environmental disrupting chemicals, people get very concerned about really minimizing their exposures, but they don't realize they're unnecessarily increasing their stress level to a point probably beyond what these EDCs would actually, cause, harm.
Yeah.
Again, I think that I say use common sense, but, if you feel like you're in a situation that is putting you at an unnecessarily like high risk, you're in somewhere that says there's radiation safety and to wear like a suit, you should put the suit on. But beyond that, I think your exposure every day to these things, if you're part of the general population, you have to remember that that's where all our data is coming from. You are one of the average people from this data set, and everything we talked to you about chances of fertility applies to everyone in that data.
Yeah. Are you sick of going to the doctor only to have them talk at you for 15 minutes and leave without knowing exactly why they're prescribing you this certain medication and what exactly the next step is to take to optimize your health? Wouldn't it be great to finally find a doctor who actually listens to you, answers your questions, and doesn't rush you out the door? Well, at my practice, Rena Malik, MD, I aim to do just that. I specialize in taking care of patients who have issues with their sex lives, issues with their bladder, with their hormone health, or are having pain in their pelvic region or with sex. My goal is to give you the time and attention you deserve so you can leave with a clear understanding of your condition as well as our treatment plan that's optimized for your goals. During your visit, I'm 100% present with you for an entire hour. And after you leave, you can reach me. It is super easy to send me a message through our secure portal, and I'll get back to you within 24 to 48 hours. No questions asked, no hidden fees. Scheduling is easy. Just visit our website, renamalikmd.com/appointments. We see patients in both Irvine and Beverly Hills, California, and I see patients virtually in California, Florida, Illinois, Maryland, New York, New Jersey, and Virginia. Oh, and don't forget Texas. If you're outside these states, consider seeing me for an educational visit. I look forward to seeing you. I think the other important thing I want people to hear that you said is that when you have an illness, a fever, a virus, that your sperm count can go down to 0. Like, it can be dramatic. And I think that that is really important for people to understand, because if you say you get an at-home sperm test, and I want to talk about those too, say you buy one, say you do it at home, and you just had a fever like a week ago even, it can really dramatically impact your semen parameters and then create a lot of stress.
Yeah. And as I said earlier, like, the life cycle of a sperm is 72 to 74 days. And so if you had people have a fever a month ago, forget that they had that fever a month ago, come in and get a test. And this is one of the reasons the workup usually is 2 tests if one is abnormal over the course of several months to avoid something like this. I mean, getting a fertility check is a double-edged sword. At one point, maybe you get some kind of fictitious information that then increases your stress, which is then going to drop your sperm count. So again, it's good to talk to somebody before getting a semen test. I think at least telling somebody that you're in your usual state of health. Normally people are trying to conceive, but you can see how, some of your decisions, although they're laid with the best intent, like, you're not thinking about the consequences. And I think that's something that's changed a lot in medicine and, in urology as well. I mean, we do prostate biopsies for people with elevated biomarkers for, prostate cancer, but beyond the immediate risks of the procedure are the potential anxiety risks of knowing or not knowing, a diagnosis. And I think the same is true here.
Yeah. So talk about what you think about at-home sperm tests in terms of quality, and then what should people know before they take one?
Yeah, I think that the quality of a lot of them is actually increasingly good. And truthfully, even if they're just used as a potential screening tool for, somebody's been trying for 6 months, they have some curiosity and they get it and it says sperm less than 5 million, which some of them will, that should be a trigger to see somebody about it. If they say the sperm test is, completely normal, it shows normal counts, I think a lot of them are fairly accurate. The question I always ask before someone does something, and I ask myself this before I order tests on a patient, is what am I looking for? What am I ordering this for? So if you go out and get an at-home sperm test, I think you need to ask yourself that before you get it. If you're saying, I just want to know right now in time, am I fertile? I think it's a reasonable, thing to pursue. On the flip side of that, what's the downside of doing this? Well, let's say it shows that you have no sperm. Let's say it shows this. What is that going to do to you and your lifestyle? Do you currently have a partner that you're trying to conceive with? Is this going to change, what you're doing? I think it's important to think of those consequences as well. And if you're like, I need to know, again, completely reasonable to do so, but there may be some stress on the back end, finding something that you did not want to find.
Yeah.
If you're actively trying to conceive, I mean, it would be just like seeing somebody, and that information is obviously super helpful.
Errors in taking at-home sperm tests that you can kind of caution people about?
I think getting an incomplete collection And for me, at least, again, if I'm seeing that and then we have a volume reported, all I'm thinking about is that maybe the ejaculate's not all coming out. Maybe it's going the wrong way. Maybe there's some other thing going on. That's the biggest one that I've seen, is just not collecting a complete sample.
Okay. And volume. I think people always want to know what's normal and how much volume is normal. And why is my volume decreasing versus increasing? Sometimes it's small, sometimes it's large. Maybe we can talk about that a little bit.
I mean, so if we talk about what comprises the vast majority of the ejaculate, it's the seminal fluid from the seminal vesicles, and normal ejaculate volume. If you look at the WHO standards, and again, these are the people that put down, all healthy men that are able to have children, is somewhere in that 1.5 milliliter range, which isn't all that much. That's normal. Average is somewhere slightly higher than that 2.25. Like, again, these are fairly small amounts. Now, there are things you can do to potentially increase your ejaculate volume. There are hormonal alterations you can make, but realistically speaking, like, that is a normal ejaculate volume. I also get asked about like the force of your ejaculate. Now, again, these are very tightly coordinated process, being able to put that ejaculate in your urethra and then being able to actually evacuate it. I mean, there are differences. If you have a learned behavior and you're pitching, the velocity with you throw a ball, just because you're not under complete control of your ejaculate, a lot of these are musculoskeletal issues. If you're tired, you're fatigued, you're stressed, all these things are going to influence, partially the amount of ejaculate as well as the velocity and what you're going to experience. So this is very much part of the sexual response cycle.
So hormonal changes, you mean testosterone?
Primarily testosterone, yeah.
Yeah. But I don't think I would recommend taking testosterone just for the purposes of increasing your semen volume.
That's kind of what I was alluding to. I mean, there are things that could be done, but I don't think medically I would recommend.
So from my understanding, though, while we know testosterone is very highly linked to ejaculatory dysfunction potentially, it doesn't always correct it in terms of like premature or delayed. Am I correct on that?
Yeah. Again, I think that there are a lot of nuance to, is this somebody who has lifelong premature ejaculation? Is this somebody who has lifelong? In those cases, probably unlikely to correct that sexual dysfunction, because that is probably some either combined neurologic condition, something that's been going, maybe has some, psychiatric involvement, and requires something else. People that have acquired delayed ejaculation, or people that are taking 30 plus minutes to ejaculate, whereas previously it was 5 to 7 to 10. You check their testosterone is abnormal, that person may benefit. Likewise, premature, not as much, but again, like you were trying to normalize somebody who has a new finding. It's a shame we don't have baseline testosterone to know if that really was a driver. But if you had somebody's testosterone, it was 500, and they come back and now it's 250 reproducibly, you're like, well, I'm seeing this, I'm seeing a symptom. It's possible these are related.
Yeah.
Whereas all we have to go by is some lab at a time point and a symptom at a time point.
So probably the lack of response is because those people were actually always at that testosterone level, or that's sort of their normal, and replacing it is not actually changing that symptom. That symptom is maybe for other reasons.
Presumably. I mean, again, we can open up a whole can of worms with testosterone, but the symptoms are so non-specific, or not like, we don't know if it's testosterone, the stress, the energy, anything. It's very hard to just take one medication, like this cures everything. That's not the case for most people.
Yeah. What are other things that people can do to prevent infertility?
Well, I mentioned, not unnecessarily exposing yourself to risk, not exposing yourself to hot tubs. We didn't talk too much about like smoking and alcohol and marijuana. I think drinking in moderation is okay. There's pretty good data that 1 to 2 drinks a night does not significantly impair spermatogenesis. Now, if you drink substantially, you can actually shut down your endocrine axis and turn your testosterone down to a point where it may substantially impact your fertility. Smoking's been shown to reduce motility and counts. Marijuana is an interesting one. There are a number of studies showing that it decreases the shape of the sperm count. But there have also been some studies specifically in subfertile men that it's actually shown increases in sperm count. I would interpret a lot of these with caution. Again, I like to tell my patients that it's unlikely to be beneficial. There's a small number of these studies. It could be harmful. In most cases, I would just suggest either minimizing or cutting it out. I mean, if you're really doing everything you can to try to prevent a problem, but I do think we need more data in this space.
Do you think there's a dose response with the marijuana?
Absolutely. I published a paper looking at an inverse like U-shaped response with testosterone and THC, and people at low levels may have some increase, but as the level goes up, that their testosterone levels go down. I'm sure there's likely some explanation that way. We know there are cannabinoid receptors on sperm. We just don't know exactly if they're activating or at some levels, or what strain of THC or what terpene profile. I mean, this is really getting in the weeds, but I do think we need good literature here before we're able to make recommendations.
Yeah. Why do you think we have cannabinoid receptors on sperm? Like, what do you think evolutionarily, or what do you think physiologically that benefits?
A lot of the endocannabinoids have to do with, mood and feeling good. And I don't know if it's some holdover from that. I don't know if it, has to do with like the pleasure of orgasm, that it activates them in a certain way. I really don't have a good answer, but my suspicion is that it's more down that pathway than like taking in an exogenous source from, a plant.
Yeah. Okay. In terms of trying to conceive, so we've already established it should be in that 3 to 5 day window when you're ovulating. How can people optimize their chances for conception? Are there certain positions they should use? Are there certain techniques they should use?
Yeah, I mean, beyond the frequency of ejaculation, the most important thing is being able to ejaculate in your partner. I frequently, is missionary better? Should I be positioned like this? And, there are some papers looking at this, but the commonality is really, if you cannot ejaculate in your partner, you are not going to be able to conceive a child. And it's such a, personal thing that's usually where my conversations go. It's like, if this is what works for you two, this is what will work the best. Because if you can't do it in a different position and achieve climax, again, there's a 0% chance if there is no semen.
So say you can climax in any position. I mean, say there are people who certainly are very adventurous, try multiple different positions, are able to climax in multiple different positions. Is there one that's better?
No.
Okay.
No.
Okay. We've talked about some causes of fertility. I think we've covered quite a few, actually. Is there anything we missed in terms of causes of infertility?
I mean, I think the big ones are their genetic causes, which we talked a little bit about Klinefelters. There's some very rare mutations that cause the lack of sperm, to be produced at all. Unfortunately, I talked about azoospermia, but 1% of the male population has no sperm. That's not insignificant.
That's huge.
Think about that.
1%.
Think about that. You go to a football game or a basketball game and you look in a section of 100 guys, and one of those people does not have sperm. Now, there are different types of azoospermia, and some of them are surgically correctable or, ability to harvest sperm. Some of them are issues whether you're producing very little. That we do have treatments for these men, but they're certainly not 100% successful.
Okay. In terms of Klinefelters, I know you mentioned it. Is this something that's typically diagnosed later in life?
It depends on kind of how it manifests. Some people, it's very obvious when they're younger. Their testicles are very small. They don't go through puberty at the appropriate time. The pediatrician's doing an appropriate exam saying something's wrong here. I'm going to send them to an endocrinologist. But I don't infrequently find men that have made it to my clinic that have never been diagnosed. And again, I can't say if that's a lack of routine physicals or what, but it's a common condition. We're talking like 1 to 600 or 1 to 650 men have Klinefelters. And Klinefelters is simply, an extra X chromosome. So somebody, instead of being XY, which would be a typical male, is XXY. The most common features people have are either decreased testosterone. Typically, people have very low, and a lot of times that azoospermia condition men present with. So they have infertility. They may have increased breast growth. Something I find that isn't 100% specific, but I'll often ask men when I have some suspicions, like, are you the tallest person in your family? And a lot of these men are like, yeah, I am by inches taller than all my cousins, parents, etc.
Don't freak out if you're the tallest person, though.
True.
Okay, so that's just a genetic test. It's a blood test, right?
Blood test.
Yeah. Okay. What about things like wearing boxers versus briefs?
There have been a number of studies on this. I think that when we interpret semen tests, it's important to remember that these are people that are able to conceive. And the chances of a choice of boxers versus briefs in any of these studies of putting you from normal to abnormal was pretty much zero. Now, it may slightly affect things. We've seen these studies where tighter fitting underwear, again, they don't allow heat to escape. So people's concentrations may be slightly lower. The best study on this was actually just an observational study where they surveyed people. And what was interesting is that there wasn't any difference in the ability to conceive or have a child. So as I said earlier, we can perseverate on this small, like my concentration went down by 5%, but really, I don't think that's something to care about. The question is, are you able to get pregnant? And when we look at boxers versus briefs, doesn't seem to affect that endpoint. So that, I presume, is what you're interested in, is having a child, not having 5% more sperm than you had previously.
Right. And I think that's the real important thing, is that even a lot of these studies don't actually look at that endpoint, because that's a very challenging endpoint. You need a lot of patients to recruit in a study that are subfertile to then see which one of them is going to get pregnant. And I mean, it's not impossible, but it's just a lot more recruitment, which is more money, which is more challenging.
And it's a long-time follow-up too. Like, right, you can get a semen test 5 days later, 72 days later, I have to make sure that you've waited for a new cycle spermatogenesis, but waiting for a pregnancy, a live birth, I mean, we're talking months now, years to do this. I think one of the best examples of this is a lot of these infertility supplements, which we haven't talked about. But, people are advertising, lycopene, zinc, selenium, carnitine, and there are small single arm and even some small randomized controlled trials, things like CoQ10, that have shown some benefit. However, there are also very large, well-controlled, randomized controlled trials that show no benefit for a lot of different cocktails. And again, their outcomes are the right ones. They are childbirth, pregnancy rates. They're not semen parameters. And even in their semen parameter data, they didn't see a difference between any of these groups of antioxidants and placebo. In fact, there was a trend towards people being on antioxidants to having increased DNA damage to their sperm compared to the placebo effect. So I think that, before I recommend a supplement, we really would need better data. Now, as somebody who is, a personal trainer in a previous life and care a lot about trying to optimize your own health, it's difficult to do any nutritional study well, because you would presume you would know somebody's baseline intake of zinc or selenium before you supplement it to know what you're doing. And for that reason, I often do recommend people take a multivitamin. I do not think super supplementation of selenium, zinc, vitamin C, D, E change your fertility. But I do think that if somebody had an unrecognized vitamin deficiency, that could affect their reproductive health. And rather than do this huge workup, a metabolic cart to see whether or not they have one, multivitamins are relatively innocuous and expensive. If there was an issue, the FDA probably would have, shut down a specific company. I would look for something that is not expensive and has been on the market for a long time.
Yeah, usually by a reputable company that's been around for a long time, because they follow the guidelines and regulations a little bit more to the T, I would say, than smaller companies.
Yeah, and again, the way the FDA reacts to nutraceuticals and vitamins and minerals is that they react to reports. And if something's been around for 30, 40, 50 years, and they haven't got reports that say there's a contamination danger, I developed X, Y, or Z, it's much more likely to be safe than something that's new to the market and makes a lot of promises and has yet to be proven either effective or safe.
I think that's really important, because I think a lot of people will spend a lot of money, and you just mentioned that there could be harm. There could be DNA damage potentially. We don't know.
We don't know. I mean, it wasn't statistically significant. It was trending toward that, but the point is, we don't think it is helping. If you go on the FDA's website and you just pull up recalls in this nutraceutical, you will find a lot of men's health supplements specifically. Now, a lot of them are contaminated with Viagra or Cialis-like medications. But if you scroll down far enough, you'll see some have things like cadmium, heavy metal, lead, things that are actually, we know to be harmful to sperm. So I would use anything at your own risk. I would definitely do research. And again, from my standpoint, it is more about not having a deficiency in something than it is this one supplement will make you more fertile.
Quick break from this episode to let you know I am so grateful that you're spending part of your day with me. I started creating content online to empower people to learn more about their bodies without needing to go see a doctor, pay a copay, wait in a waiting room, or find parking. And it has been one of the most rewarding experiences of my life. If you want to help support our mission of providing free education, please consider joining our premium membership. There you will have access to ad-free episodes, which are released early, as well as free transcripts and the opportunity to ask me anything. And these questions are answered in our monthly AMA episodes. Support the show and join today at renamalik.supercast.com. Can't wait to see you there.
What about cell phones and laptops?
That's tough. I mean, laptops, we talked about heat. Is it possible that somebody could have a laptop on their lap long enough that it could generate heat, that could prevent heat exchange? Sure. Again, I would just be mindful. I'd use common sense. Do not cause your testicles to overheat. Now, that's not saying don't take a warm shower. There are really good ways that water can evaporate, and it probably is not going to be a big difference. But like submerging in a hot pool of water or putting, a laptop that gets really hot on your lap, I would avoid that. I don't, at the end of the day, I don't think it's going to help. It's certainly not going to help you conceive.
Yeah.
Cell phones, on the other hand, there have been several reports looking at cell phones, and the newer ones seem to be more promising than the older ones. They're likely to be not harmful. I think the real interesting thing is a lot of these are, survey data. And they're like the number of times you use a cell phone in a day correlates to a decreased sperm count. It's like, but, things have changed over the last several decades. The functionality of a phone in terms of like answering a call to text messaging to scrolling, online, like how do we determine how long somebody used it? I don't think we have great data in this space. The actual last survey I saw on this was a few years ago, and it determined it doesn't matter where your cell phone is. It's just number of uses. You're constantly busy walking around people. I would put this in that EDC category of this is probably an unavoidable consequence of life. You are very likely to be doing the same thing the average American is doing. And the average American is the person we build these risk models on for fertility. So unless if you are on your phone all day, every day, is there a chance you're doing something? Maybe. But I would argue that, beyond that, you're probably not getting out, being active, and doing things that would otherwise be helpful.
Should you avoid keeping it in your front pocket?
So that was looked at on the survey, and it showed no difference.
Okay.
So that's why I'm skeptical of the phones causing problems, and more that the lifestyle of people on their phones is people that are more sedentary, inactive, people that aren't taking care of. But again, that's what goes well beyond the study. I mean, as I said, like it's so important. I know you definitely bring this up in all of your other talks, that you have to look at the two variables mentioned, cell phones, fertility, and ask, is there something else in this population of cell phones users that is driving this outside of the cell phone? And I really think that this is a third variable problem.
Yeah. And unfortunately, cell phones are a part of our lives. And like, if you're a busy person, you need to be accessible, and very often you're using it for business. The other big topic you talked about wet heat, but what about saunas? And then what about extreme colds, like cold plunges?
If you think about how our body loses heat, if you don't have the ability to have any evaporation and your testicles get warmer, again, this is the same principle as a fever or a varicose, which are dilated veins, that heat can be disruptive to sperm creation. We know that testicles are out of the body because that is where spermatogenesis, or creation of sperm, occurs. It's about a centigrade degree lower than core temperature. And we know that when people have undescended testicles, which again, there are other reasons why they may have problems with sperm production, but that those testicles can produce testosterone, but are way less good at producing active sperm. So increased amounts of heat that do not allow heat exchange, potentially like a sauna, I would avoid those. In terms of extreme cold temperature, I know that cold plunges definitely are a thing right now. I think similar data exists for extreme temperature changes. Now, we could argue on the merits of slightly cooling down the scrotum, but extremely cooling down the scrotum, this is taking me back to when I was a trainer, where people would take ice baths after extreme exercise. And there's actually data looking at testosterone levels. I wouldn't admit to it being good data. We're talking about like 8 to 12, participants, but they've shown that people that recover an ice bath versus non-ice bath, people in the ice bath have lower testosterone levels immediately afterwards. So again, kind of following that logic, which I have zero good evidence to say hurts fertility, but following that logic, I think it's more likely to do harm than it would be to be beneficial.
Do you think it's time restricted? Like, we know heat obviously has a longer impact, right? So if you have a fever, right, you could have subfertility for a month, right? Or 72 days. But do you think cold is more time restricted in terms of how it affects sperm production?
I honestly don't know. I really don't know. I mean, I can tell you from the studies where they compared, people that were in hot versus cold showers, which showed almost, no difference, that it's low temperature variations, probably not a big deal. But I don't know what these
people are going into ice plunges. It's not low temperature variations.
I think this is a place that is ripe for study, that we need to, as professionals, figure out whether or not this is potentially dangerous. I mean, we do not have good data here.
Yeah, we don't. So we've talked about a lot of different sort of hot topics in terms of causes of infertility, but what can someone who's seeing an infertility doctor expect? Because I think this is a huge fear-inducing experience for men.
I often see people with their partners, which I appreciate because it allows me to kind of get a couple's history, because infertility is not a one-person problem. It is a couple problem. So people that are doing this, I highly encourage you to bring your partner there. Realize there are a lot of questions you may not know. I ask a lot about, partner's menstrual cycle and everything, just because again, this is very much a couple's issue. From the male side of things, really the infertility workup involves four things. It involves me asking you a ton of questions, of which we covered a lot of the things I'm asking about: potentially previous infections that you've had, any history of surgery on the testicles or things that may have happened while you were born, family history of different conditions. It involves a physical exam, me feeling for making sure that you have adequately sized testicles, that there's not a cancer in your testicles, that you have all the structures like the vas deferens needed to get sperm from the testicle to the penis. It involves making sure that there aren't dilated blood vessels or something called a varicocele, which can increase the temperature of the testicle and thereby decrease people's fertility potential. In fact, that's one of the most common reversible causes of male factor infertility. So the exam is incredibly important. Along with the exam, we make sure that the penis is in the right position, that the urethra is in the right position. There's also a lot of talk about erectile issues and ejaculatory issues. I can't tell you the number of men that come in for fertility, like, I'm not ejaculating on my partner. And then the partner looks and is like, oh, you're not. And that requires a whole nother layer of a conversation. But that's important because, again, if you're not going to ejaculate on your partner or you're losing your erection, I agree. It is definitely associated with a lot of potential embarrassment. These are easily correctable conditions. They are very common. The men who are trying to conceive, there's a huge increase in number of men with erectile dysfunction around conception. When something that is supposed to be, a leisure time activity becomes, a business activity, it causes stress. And we know stress influences testosterone. We know stress influences erections. So, this is something that's super important to address. The other part of the evaluation, they should expect some degree of hormone levels being checked, whether it's, blood test for testosterone. And again, maybe it's a cry for help, making sure that they see the primary because they came in and their blood pressure was high. It looks like there's somebody who hasn't seen a doctor in the better part of a decade. The crux of everything, though, is going to be that semen test. Really, the vast majority of the data is going to come from that. And then tests beyond that will be driven by that.
So in terms of not ejaculating in your partner, are you alluding to that they're faking it, or that they're not able to ejaculate, they're not climaxing, they know they're having low ejaculate? Like, what exactly are you seeing?
Yeah, a lot of it is usually erectile dysfunction. That I don't know if they fake finishing or what happens, but a lot of the people will say, we were having sex and I lose my erection. And then I don't know what the communication is like between couples, but it is not something I see infrequently.
But their partner's surprised.
Sometimes the partner's like, yeah, this is definitely an issue. Really depends on where the education of the couple. But I've certainly had some partners really caught off guard that the male comes out and says that they are not able to finish. I don't want to speak for these couples, but there must be some form of miscommunication happening.
Okay. And sometimes it's just the erectile dysfunction.
A lot. It's rare I'm seeing people for profoundly delayed ejaculation. Again, could be stress induced, but the stress in terms of erectile function is around this time. It's a very sensitive time in people's life. They want to have a child. Some of these people are newlyweds. They had zero problems, and all of a sudden they get in their own head, and all that they've created something that they didn't have previously.
Are you feeling in a rut in the bedroom, wishing you had the kind of sex life you could brag about? I've spent years helping patients and creating content for people all around the world to improve and optimize their sex life. Today, you can get my knowledge for 100% free with my new ebook called Better Sex, Better Life. In this ebook, I review my top 10 tips for improving your sex life, all from the comfort of your own home. All you have to do is go to renamalikmd.com/morepleasure to download it for free today.
You've mentioned varicoceles. So if you find a varicocele, which is sort of what I tell patients is like you feel down in your testicles and you feel like a bag of worms. And that's kind of what a varicocele is. Talk about what it takes to repair that and what people can expect after repair in terms of return of fertility.
Varicoceles are a hot topic. And they are these dilated veins, the veins that drain the testicle. There are several different pathways for blood to get out. So if they're removed, it doesn't cause all blood to be trapped in the testicle. We think the reason that they're harmful is, again, that your core temperature, your blood builds up in these areas and it overheats the testicles. And yes, a varicocele on one side can affect both testicles. I get asked that all the time. If it's on my left, why is my right one not producing? But we've shown in animal models that that certainly can be the case. Also in human models, repairing one side profoundly will increase sperm counts. I think the most important thing here is, number one, there are a lot of unnecessary lab and imaging tests ordered to diagnose things, and people find incidental varicoceles that are found in ultrasound that you come in to see a fertility specialist and say, I don't feel that. That's not because it's not there, but it's because it is not a clinically relevant varicoceles. Those have never been shown to improve sperm parameters. So if an infertility specialist cannot feel it, I would not worry about it. The second part is that, we have fairly good guidelines in this space. And if your semen parameters are grossly normal and you have a varicocele and you haven't been trying for the appropriate amount of time, I don't think it warrants immediate correction. What we do know is that for people that struggle and have a varicocele, for people that have semen parameter abnormalities, there may be concern that these are going to get worse over time. For people that are worried about their fertility potential, they come with a varicocele at 18 because they're referred from their pediatrician. I repeat semen tests every year or two, and if they start to decline or we start to get worried, those things would warrant correction. Correction is done in several different ways. I mean, the gold standard would be microsurgical correction with a small incision right next to the penis. The entire cord or the structure that leads down to your testicles brought up, and all these veins are meticulously tied off or clipped off. Recovery is in general about a 2-week procedure without heavy lifting, aerobic activity, or sexual activity. And if you remember what I said about the life cycle of the sperm, we're waiting. Usually I tell people 3 to 6 months. Sometimes there's a transient decrease in semen parameters just to all the inflammation that's there. And there's a small number of men, 5 to 10%, that don't see parameter increases. On the flip side, there are men that don't see parameter increases but immediately have a pregnancy. And therein lies a problem with our bulk semen parameters. They're a good picture, but they really do not tell the entire tale. We certainly see correcting varicoceles helps fertility. In fact, one of the only randomized controlled trials in this space was a randomized controlled trial by Abdel Magid, where they looked at men with varicocele, men without, and the men they treated with varicocele had a number needed to treat. So number of varicocele needed to treat of 5 to increase pregnancies by 1, which is pretty remarkable to be able to do a trial like that. So I think varicoceles are an important correctable cause of male infertility when diagnosed appropriately.
Great. I just want to cover this one topic because it comes up all the time and people want to know, are there foods that are going to be good for fertility? Should they be eating dates?
I think realistically are there foods that are bad for fertility? There's not one simple thing you can eat that is going to impact your fertility. What I would recommend is if you're buying meat that you're concerned has a lot of hormones in it, you are going to ingest those that may disrupt your metabolic acid. Do I think that is something that's going to make a big difference? Probably not, unless there's like a recall that this is like hormonally tainted meat. Soy protein I get asked a lot about because some phytoestrogen conversion of that. Realistically, it would need to be a lot. It's probably more, you're not going to eat 60, 90 grams of soy protein. If you are, that may be something to make more in moderation. That really is the key, is that everything in moderation is likely going to be okay. Even with caffeine, there are studies that over 600 milligrams, you may have again, maybe people do take that much in, but I think really the key here is moderation. There isn't one thing you're going to do that is going to majorly move the needle.
In terms of dietary recommendations, whole foods, maybe Mediterranean diet is what I've heard is sort of the optimal diet. Would you agree with that?
Again, it depends what the third party variable here is. And with that Mediterranean diet, a lot of people have been shown to live healthier, have lower cardiovascular risk factors. And again, I don't know if that's what's driving this or it's the diet itself. I do think that Mediterranean diet, DASH diet, a lot of these popular diets that allow healthy lifestyles are probably similar with regards to their fertility potential. But again, for that third variable reason.
Let's talk about vasectomies. I think there's a lot of anxiety about vasectomies. 1, for people who are considering them. And 2, there's an uptick in vasectomies right now with young men getting vasectomies, thinking they can reverse them later on.
Yeah. Ever since that Roe v. Wade ruling, we've seen quite a significant increase in the number of consults in young men. We're also seeing people have children later, marry later, which does create this situation of, well, I'm not ready now, but in 10 years, I may be ready. What I tell all patients is that this really should be viewed as irreversible. Can it be reversed? Yes. We know that 6% of people attempt to do something afterwards, either reverse the vasectomy or get a sperm extraction. And I think that's important to understand that vasectomy is a roadblock between the testicle and the penis. That doesn't mean the testicle is not still producing sperm, but I will tell you what I tell everyone is that it is fairly inexpensive to do. It is fairly quick to do. It is much more expensive and way less quick to undo. So if you are somebody that is sure they don't want biological children, even if you're young, I think if you have a rational thought process, it makes sense. But if there's that 1%, 5% chance you may in the future, probably not the best form of contraception for you.
So you said 6% go back into,
Yeah.
that's,
Yeah.
I wonder if that's going to go up.
I would bet it is, but I don't know. I mean, truthfully, we've seen a lot of numbers where we thought the divorce rate may go higher, and we're seeing lower divorce rate in younger people, higher divorce rate in older people. I mean, I would agree with you. Tentatively, I would imagine that number would go up, but I also wouldn't be surprised if it stayed the same, where there was some unknown interaction and nobody's getting vasectomy reversals.
Well, on the flip side of young people having less divorces, there's less marriages.
That's absolutely true.
Yeah. What is the success rate of a reversal, and what can people sort of expect if that's something they're like, I don't care, I'm going to go through it even if it's more expensive, even if it's more time consuming?
Reversals, really the drivers on success rate has to do with time from vasectomy to time of reversal. And if you're getting the vasectomy at 21 and you're 35 and want to have children, you have a very long, what we'd say, obstructive interval. Success rates, though, even in those kind of circumstances, are as high as 70%, with pregnancy rates up to 30%. I mean, this data is somewhat antiquated. This is a lot of the numbers we quote are from this paper, from several decades ago, but it's the largest study of people getting vasectomy or reversals. Almost 1,500 people, followed by expert surgeons for the better part of a decade. So it's probably the best data that we're going to have in this space. But really, the success rate varies from high 60s, low 70s to 97% if your obstructive interval was less than 3 years.
But these are we're thinking 10 years out, right?
Yeah, exactly. So that's my concern, is that I think if we were to redo this study, the overall success rate will be lower because that obstructive interval that we're seeing is going to be longer than what traditional vasectomy reversal times were. And the other part of this, though, is that when that paper was authored, we didn't have in vitro fertilization with ICSI. And now a lot of these male factors that we're seeing are just completely bypassed. I wouldn't be surprised if there were more sperm extractions and IVF in the future rather than vasectomy reversals.
Yeah.
And I want to put a plug out here that there's insurance issues with getting IVF for fertility-related conditions, azoospermia, people with very low sperm counts or low moving sperm counts. There are several mandated states. I'm from Chicago. Illinois is a mandated state to provide insurance for fertility coverage for in vitro. And now being in Kansas, we don't have that luxury. But the reason I bring this up is that vasectomy is an exclusion. If you get a vasectomy, your insurance company is almost never going to pay for a sperm extraction or in vitro fertilization. So as I said, quick and easy to do, not expensive to do, very expensive and time consuming to undo.
We talked about other forms of conception. Now there's plenty forms of conception available. Condoms typically are the only one that men can use currently that they can be in charge of. In terms of the birth control, I've talked about some of the studies that are, ongoing for birth control. What can you say about what seems most promising in terms of male birth control? And do you think we're going to see one that's going to be on the market for men at any point in the near future?
Near future, probably not. I mean, we've got a bunch of phase 2 clinical trials looking at hormonal agents. There's some phase 2 and 3 clinical trials looking at non-hormonal agents in the UK. The biggest issue is, how do we define success? Again, we talked about this earlier. In females, it's a 1 or a 0. You're ovulating or you're not ovulating. In men, is it less than 5 million sperm? Is it less than 1 million motile sperm? Is it 500,000? And these trials have slightly different numbers of how they define success. The problem is, to a patient, definition of success is not having a pregnancy.
Yeah.
And we all know that 1 million sperm can certainly get someone pregnant. The real question is going to be long-term, what are the efficacy rates of these medications? I do think that at least one of these is going to come to market, whether it's a hormonal-based either gel preparation or injection preparation, where we're combining testosterone and pregnenolone or another variation of that, or it's one of these non-hormonal contraceptives that bind to the sperm and stop motility, or bind to the structures inside the actual precursor cells. I think it's yet to be determined. But again, I think we need to be cautious about what we define as success.
Yeah. I think people ask me sometimes, like, well, if testosterone can cause infertility, why don't we just put men on testosterone?
Yeah, I think that is a logical statement. The problem with that is there are obviously other side effects of testosterone. And then we start talking about the reversibility of that, right? I mean, we have a known quantity of reversibility with vasectomies. There is decent literature. Lipschultz put out, recovery of testicles after steroid use, including testosterone. But again, I would say the same thing I told everyone. I have patients that are testosterone users or anabolic steroid users. They still have pregnancies. So what do you define as success? Right. I mean, you can try it. I have plenty of people on testosterone. They're like, do I need a vasectomy? I give them the same speech. I cannot guarantee you less than a 1 in 2,000 failure rate unless I do your vasectomy. Your sperm count may be this today, but it could be something more tomorrow. You miss an injection. What happens to your sperm count reflected in 3 months? I mean, again, if you want the assurance of having a very, very low, and again, we quote about 1 in 2,000 failure rate with vasectomies, then you should get a vasectomy.
Yeah. You've done a lot of important work on testosterone deficiency, and we've actually seen a decline in testosterone in young men. Tell us a little bit about what the trends have been and then why you think that is.
Yeah, so this is some research we did several years ago. There's a very large national survey-based laboratory test called the National Health and Nutrition Examination Survey. And what we did is we looked at, over the last several decades, just the average testosterone levels of men 18 to 40. And what we found is that by decade, we were seeing a significant decrease in testosterone levels, which led us to draw several conclusions. The first was, is there an epidemic of other comorbidities like obesity or BMI that are really contributing, or at least in part, to this? And the answer is yes and no. It's yes, because those levels increased when we controlled for BMI, but they didn't completely change. I mean, there still is a signal that there are decreasing testosterone levels over the last several decades. I mean, some of our hypotheses were, number one, maybe the way we measure testosterone has changed over the decades rather than it being, beyond a laboratory abnormality. Maybe it's due to potential in utero exposures. We talked about, environmental disrupting chemicals. Is it due to lifestyle? We also, in the same survey, can see trends in different dietary changes, people eating more calories, people eating more carbohydrates, people eating less fats. There are a number of hypotheses for this. All we know is that there is a trend that shows a slightly decreased level in men over the last several decades, in young men specifically.
And why do you think that is?
Yeah, I think a lot of this is likely due to either the assay that we used in that study. The gold standard is this liquid chromatography tandem mass spectrometry, which is, again, calibrated by the CDC. Some of the original assays in the studies were radioisotope assays, which we know to be a little bit less precise, meaning the values may be slightly too high or slightly too low. But if you really think about it, if it's less precise than the errors on both sides, you would still think that the average would be similar. So I don't think that it really explains the whole picture. I really do think that changes in overall health, again, increasing BMI, increasing incidence of type 2 diabetes and high blood pressure in younger men likely has a bigger contributor than anything to do with the test itself.
You also did a study that found that men with low testosterone were at higher risk for premature death.
I worked with Dr. Platts. She's one of the epidemiologists at Johns Hopkins on this, and she's done a tremendous amount of work looking at the epidemiology of testosterone. And again, this is another study coming from that same data set. And when we originally looked at this, I remember having these conversations saying, we need to control for cardiovascular disease, we need to control for BMI, smoking status, all these other things that could confound the data, being like, is this due to testosterone or not? And after a very long discussion, she's like, do we really want to do that? Like, we have a problem here. You're telling me comorbidity leads to low testosterone, which then leads to increased comorbidity. You're also telling me that low testosterone independently leads to comorbidity. So now we have this bidirectional relationship of comorbidity and testosterone, and we don't know necessarily what has come first, but we do have an outcome measure that people with lower testosterones do die at younger ages than men with normal testosterone levels. And really this came down to, should we be screening people for testosterone, but not as a motivation to necessarily replace their testosterone, but more of a motivation to use it as potentially a biomarker for their health and to get people to treat their comorbid conditions. Again, this is, I feel like I'm on a soapbox here, but really, like, taking care of yourself is so important. Increasing exercise, having a well-balanced diet, probably most importantly, really is weight loss for a lot of them. We have seen, again, an epidemic of people with obesity, which I'm sure you've done another talk on all these weight loss agents, but really the cornerstone of this paper was to motivate people to take control of their life and use testosterone more as a biomarker of their health, rather than saying simply replacing it is going to change their longevity.
Yeah, I think that is really powerful. But the crazy part is we don't know what comes first.
I agree. And that's what makes it difficult. And that's ultimately why we decided to not control this paper for anything, because if you look at the AUA testosterone deficiency guidelines, the first line treatment is lifestyle modifications. And you know what helps with high blood pressure and obesity? Lifestyle modifications. So the same treatment actually treats the vast majority of these interrelated conditions, which again, like, is why I think those things are so much more important than focusing on one variable. It should be focused on a holistic change rather than just your testosterone, just your blood pressure.
So could one argue, and I don't necessarily agree with this, but could one argue that if you have low testosterone and you replace that testosterone, it'll be easier for you to lose weight and easier for you to gain muscle, and ideally that will then improve the comorbid conditions?
One could argue that. There are studies looking at weight loss through behavioral modifications and testosterone versus behavioral modifications alone. And they have certainly shown that men are more likely to succeed with some of these being on testosterone. Again, there are risks of testosterone therapy. I think balancing these things is very important. It depends how old a person is, the person's fertility potential, the other, potential unintended side effects of using testosterone therapy. But we do have data to show that people are more successful with these interventions when they have a plan that does include testosterone. But I do not think by any means this is a, one size fits all model. Almost everyone, I would argue, should try these changes themselves before seeking a medication to change their weight, etc.
I know you've also done some work in the misinformation space, as have I. But what do you think is the most damaging misinformation that men are getting on social media or online, whether it's related to infertility or testosterone?
I just spent a bunch of time about screening, just telling you that we may want to screen for testosterone. I think the most damaging thing I've seen is people perseverating about the number. I have so many patients like, but my number's only 350. Oh, my number's 400 and it should be 457. That's the median value at my age. That number, for the most part, is relatively meaningless. A lot of the way we treat people is based on their symptoms. So rather than perseverate over what that number is compared to someone else, I would be trying to figure out why you have the feelings that you currently do. If you have decreased sex drive, if you have infertility, if you have all these other constellation of symptoms that may constitute testosterone deficiency, rather than just perseverating on a level. Because I think that's how a lot of these marketing companies take advantage of people. They say, oh, your T is low normal. I still don't understand really what that means. I mean, we have great data to define what a normal testosterone level is by age and comorbidity status even. And again, we don't treat people who are in the 30th percentile for any other condition. So I would not perseverate on the number. I would really make sure that you understand how you feel and where you want to be at the end of the day.
Yeah, I think that's really, really important. So we end all our episodes with a few questions that we ask everybody. And this can be related to your field. It cannot be. What is one health hack or life hack that you would share?
I know you probably recently talked about different dietary modifications. I have been somebody that's done time restricted eating for, 8+ years. At the end of the day, calorie counting can be very challenging. I think the easiest thing I used to do when I was a trainer with people was write down everything you eat. I promise you don't even need me. You can figure out how to self-modulate your own behavior. It is a high investment cost, but from like a trainer perspective, it is also I want to know if you are in the pre-contemplative, the contemplative, if you're ready to make a change, like what phase of decision making you're in. And you can prove to yourself very quickly if you want to lose weight. If you're willing to do that exercise, I promise you'll be able to figure out what you need to do without, needing a personal trainer or something else. And then my point with time restrictive eating is it's way easier to use a window than it is to count all the food or calories that you eat.
What's something you know now in life that you wish you knew earlier?
This is going to sound really trite, but like listen to your parents. I mean, I swear there are so many times that, now I'm like, God, they were so right about things. And I mean, it ranges from like decisions, going to college or medical school and beyond. And like, honestly, now it's like parenting. It's like, you should do this. I'm like, man, I really wish I had listened to, been like, this is going to be challenging. They're like, I wish you have a child just like yourself so you can see what this, and I very much see that, but it's just, that would be the thing. Or even this by extent, like mentors, like people give you advice because most of the time they want you to succeed. Whether you take it as a slight or not is on you, but really people genuinely want you to succeed. So figure out their perspective.
Especially if they have your best interest in mind. I mean, some people don't. And I think those people you should not take advice from. But people who have your best interest or have more experience than you in certain areas, it's always valuable to at least hear them out and then, try to take that advice.
Listen to you more.
So what was I like as a chief resident?
No, you really, I said earlier, you were really good. I think you drove a tight line. Like you made sure that all the patients were safe and that everyone knew what their responsibilities were. I mean, residency's tough and some chiefs run a much tighter ship than others. You were definitely more type A, which I think is important because really we have a very important job and patient safety is the most important thing. So I appreciated the amount of oversight, but again, I think the coaching is super important. I think you really got the best out of all your junior residents.
You guys were great. You guys were so great. I mean, you were awesome. Like Jake is one of these guys who like there will be cupcakes in the resident room and he's like, nope, I'm not eating them. I gotta stick to take care of my body, invest in myself. And I think that is so important. And even as a resident where most people are exhausted, fatigued, and not prioritizing their health because of all those reasons, you really were a model for a lot of people and even for me. And I think that was so great.
I appreciate that. And that one thing you said is so important is like, at the end of the day, everything I talked about is like, you need to make it your priority.
Yeah.
And that really is how change is made, is making it high priority.
Yeah. And Jake brought that intensity to everything he did. So like, no, I mean, you were a great resident. You were a great trainee. I'm sure you have come out to be a wonderful surgeon and clinician, as obviously you can see it with how he spoke today, but really like very proud of you.
Thank you. I really appreciate it.
If you woke up tomorrow and you forgot all your urology, forgot all your medicine, forgot all your training because you were a personal trainer, what would you do with your life?
Probably computer science. I actually do a lot of the EHR, electronic health record, building at my institution, and I've loved computers since I was a kid. I love coding. It's my guilty pleasure. I know
You're such a nerd.
I get made fun of quite a bit for being a nerd. But yeah, I don't know. I mean, there's something about it's like surgery in the way that you have a problem and you have a solution and you're able to get from point A to point B. I mean, it's one of the reasons I didn't do a medical specialty. It's because it's very challenging when you make suggestions and you don't see action. I like seeing action. I think that's a place that definitely has that.
Yeah. And for those of you who don't know what he means, medical, especially meaning doctors who don't do surgery versus surgeons, because we sort of like to be able to fix things quite immediately. And do you have any non-negotiables, something you have to do every single day?
Yeah, it is go to bed in a better place than I woke up. And I think, again, it's very hard sometimes in a very busy life. Doesn't matter what you do, but tough day, things happen, maybe a negative interaction with a patient, maybe a complication. In our case, maybe at a bad phone call, really sitting down and taking a few minutes just to digest life before you go to bed and make sure you reset so that you can be the best you can be the next day. I've always made, several minutes, and even on call as a resident to do that because it really does a good job of keeping you having a much more positive attitude.
That's great advice. Is there something you're working on right now that is exciting for you?
Yeah, actually, the most exciting thing is that in about 2 weeks, I'm hoping to go live with some of these EHR changes I was talking about. Well, some of my area of interest is trying to reduce physician burnout. And I've tried to pilot this form where we have questions that are directly pushed to patients that then populate in a note and then are readily extractable for prospective research projects. So rather than a physician giving a patient a questionnaire, then talking to the patient for the same question, then taking that question, then putting it into a computer, then paying somebody to extract that data point from the computer, everything should be automatically done. There shouldn't be unnecessary paperwork to the patient. There shouldn't be unnecessary time the clinician is spending. And like that efficiency is just something that I hold so valuable. And I know my colleagues do as well.
Yeah. And I think for those of you who are not in medicine, you're probably shocked that like this is something new and innovative, but there is a lot of unnecessary inefficiency, especially in large medical systems. I mean, I've now selected when he said EHR, he meant electronic health record, but I selected mine because it did some of those things and reduced some of that nonsense inefficiency. But thank you so much. Where can people find you?
I'm at the University of Kansas in Kansas City, Missouri, and I work at several different campuses around the area.
All right. Well, thank you.
Thank you so much.
Thank you guys so much for listening to my conversation with Dr. Fantus. I hope you guys enjoyed. If you're enjoying my content, be sure to subscribe on YouTube, follow the podcast on your podcast platform, and check me out on Instagram, TikTok, or Facebook. It's a great, easy way to support us so that we can continue making high quality content and reach more and more people all around the world. And as always, remember to take care of yourself because you're worth it.